Hey Ubba-Bubba, welcome to JuanMD. My name is Juan, and today I'm going to be talking about pulmonary pathologies, particularly pulmonary cancers. See, I've been studying the lung section of Step Up to Medicine 6th edition by Agabegi. I now just finished the section on lungs and respiration. I identified some topics that I think would be worth reviewing. And so, using a carefully selected meticulous randomization system, 1, 2, 3, put me in another world, dare I imagine a really different kind of me, I would be a little... I decided that I would start with a review of lung cancers. I broke it down into easily chewable chunks, and I made this outline that I hope will be helpful to all of you. So in this video, I'm gonna be talking all about lung cancers. So to start, there are four important risk factors to remember for lung cancers. And these I remember with the mnemonic SCAR. So that's S for smoking, C for COPD, A for asbestos, and R for radon. Now, smoking is the one major risk factor for a lot of diseases. And if you stop smoking, you reduce the risk for a lot of cancers, not to mention blood vessel problems, lifestyle diseases, stress, you name it. After smoking, there's COPD. Studies were done and it showed that independent from smoking, COPD was also itself a big risk factor for lung cancer. Then there's asbestos, which is associated with a lot of occupational exposure. And then there's radon that for some reason you find a lot in people's basements. Now after that, we're going to categorize the lung cancers into two major categories. That's the small cell and the non-small cell. The non-small cell can be categorized further into four subcategories: squamous, adeno, bronchoalveolar, and large cell carcinoma. Duh, the opposite of small is large, right? So large. When you consider lung cancer, you also have to consider staging, how dangerous and how metastasized the tumor is. Generally, for lung cancers, you use the TNM system, and then on top of that, for small cell carcinomas, you're also going to see the radiographic spread beyond the supraclavicular lymph nodes. Okay, so a patient has lung cancer, right? How does it present? Usually, patients will not present with symptoms until the disease is somewhat advanced. And so you have the constitutional symptoms like anorexia, weight loss, weakness, and these in general will show up with a lot of cancers. Local manifestations for lung cancers include airway involvement and recurrent pneumonia, because airway involvement, the cancer grows, blocks the airway, and stuff gets trapped down there, and that results in bacterial growth, hence recurrent pneumonia. This is more associated with squamous than most other lung cancers, but it can happen with any. Next up, you have superior vena cava syndrome, when the lung cancer blocks the flow of the blood in the superior vena cava, resulting in facial edema, arm edema, jugular venous distension. This one can happen again with all lung cancers, but it's most closely associated with small cell lung cancer. Then you can have neuropathies such as Horner syndrome, resulting in ptosis, meiosis, and anhidrosis. Then you can have phrenic nerve palsy. Remember, 3, 4, 5 keeps the phrenic alive. That's what controls breathing in the diaphragm. This happens in about 1% of patients. Then finally, you have the notorious Pancoast tumor. Now, the Pancoast tumor is a superior sulcus tumor. The apical portion of the lung blocks the sympathetic nerve chain as well as the nerves for the arm and the hand. So you can expect some sensory motor problems here, some weakness. Again, this can happen with any lung cancer. It's more closely associated with non-small cell lung cancers, particularly adenocarcinomas. Before, it was more common in squamous cell carcinomas, but as of Agabegi's latest book, it's adenocarcinomas. Next up, we have the infamous paraneoplastic syndromes. Now, the lungs, they do serve some basic physiological endocrine function, but when the tumor cells start to grow and they start to spread and they start developing a mind of their own and become naughty and start producing too many hormones, more than they should. First up, we have osteoarthropathies. This manifests with bone pain and clubbing. Osteoarthropathies are most commonly associated with adenocarcinomas and squamous cell carcinomas. Then next up, you have parathyroid hormone-related protein, and like parathyroid hormone, it gets rid of phosphate and increases calcium levels. PTHRP is associated with squamous cell carcinomas. Next up, you have the triad of SIADH, Cushing syndrome, and Eaton-Lambert syndrome, which is all associated with small cell carcinoma. Now that we've looked at how lung cancers can present, let's start our diagnostic strategy. So anatomically, first we have to locate where the cancer is, well, located. Small and squamous lung cancers are usually located centrally, whereas large and adenocarcinomas are located peripherally. This is important in guiding your biopsy and your treatment strategy. In order to see where the cancer is located, you would want to use, well, imaging. You'll start with a chest x-ray. Chest x-ray in this context is very good for lung cancers, followed by CT scan with IV contrast. Now, here's a tiny tidbit that might help. You see cavitation on a chest x-ray. This is more likely to be squamous cell carcinoma. Now, you've located the cancer. What do you do next? If you can localize a tumor, then what you would want to do is do a biopsy. Now, again, the biopsy, how you approach it, will depend on the location of the tumor. If this is located peripherally, you would want to do a transthoracic biopsy. Whereas if this is located centrally, you would want to do a bronchoscopy with an endotracheal ultrasound, followed by needle aspiration biopsy. What is located peripherally? Your large and your adenocarcinoma most of the time. Whereas usually what is central is your squamous and your small cell carcinoma. What if you are suspicious for spread of the cancer? You would want to use a PET scan. PET scan will detect the spread. Finally, how do we manage lung cancer? No metastases. If it's a small cell carcinoma, you would want to do chemotherapy plus radiation. However, if there is already some spread, start with chemotherapy. Then if the patient is responsive to chemotherapy, then you would want to do some whole brain irradiation. That is shown to prolong survival in these patients. However, if the patient has non-small cell carcinoma and the tumor is localized or not metastasized, you would want to do surgical resection. Then you'd want to do adjunctive radiation therapy. There are some new studies showing that there is benefit in using PD-1 targeting drugs, but overall prognosis for metastatic cancers isn't so high. There you have it, guys. That is my breakdown of lung cancers. So what do you guys think? Did you like it? Did you not like it? If so, press that like button down below. Then click on subscribe and hit the bell so that you can stay tuned for future videos. Until then, guys, Happy New Year, and remember to always live life to the fullest because you only have one life to live. Na 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 na.